This is Kathy Knipfer, instructor for Nursing 2333, recording the Managing Nursing Care lecture for Chapter 14 on staffing and scheduling. Staffing involves planning for hiring and deploying qualified human resources to meet the patient's needs. Scheduling involves implementation of the staffing plan by assigning unit personnel to work specific hours as well as specific days. AHRQ stands for the Agency for Healthcare Research and Quality. It conducts research on staffing, workloads, skill mix, as well as patient outcomes. If there is adequate staffing, AHRQ states there will be a decrease in medical and medication errors, a decrease in patient complications, a decrease in mortality, an improvement in patient satisfaction, a reduction in nurse fatigue, decreased nurse burnout, and also an improvement in nurse retention and job satisfaction. It is important for the nurse to know certain terms related to productivity. One of those terms is HPPD, or hours per patient day. It can be considered a unit of service for a certain department. The unit of service multiplied by the volume for a clinical area determines the number of staff that are needed in a given time period. And this formula can be adjusted for total paid staff or just for those required for the delivery of direct patient care. Full-time equivalents, or FTEs, can be direct, indirect or fixed, productive, and non-productive. Staffing principles. Nurse managers have to consider a number of variables when they begin to process and distribute FTEs into the unit staffing plan. Defining targets include the hours per patient day, HPPD, and the unit of service, or UOS. The needs are often based on some sort of a evaluation system or classification of patients. So one example would be the prototype evaluation system, where patients are classified according to DRGs into broad categories that predict patient needs. The data is plugged into an electronic decision support system and the answers come out. The factor evaluation system is considered more objective. It gives tasks, thought processes, patient care activities a time or a rating to determine hours of direct care required. The interventions are defined and associated. Staffing requirements are complex. Many factors may be considered. The manager may use computerized optimization models. They may use productivity models where a matrix is developed and then the subsequent monthly staffing schedule. Reports are submitted by the charge nurse or the manager. If it's over budget, though, reductions must be made. The NDNQI is a program of the American Nurses Association. It was established in conjunction with the ANA Patient Safety and Quality Initiative. There are 18 quality indicators that are included. They are used in quality improvement plans to prevent adverse events. So that is the goal, to prevent the adverse events. The NDNQI compares similar organizations so that they can benchmark. It also measures workforce issues related to quality of care. This includes staffing levels, turnover, RN education, and certification rates. More on staffing principles. Outcomes must be analyzed to determine staffing effectiveness. Models of care would include one based on staffing ratios. One might be based on the RN as a percentage of the direct care hour. Scheduling variables to be considered include hours of operation, shift rotation, weekend rotation, as well as vacations, holidays, sick time, and leave time. Other scheduling variables include continuing education, scheduled meetings, filled and unfilled vacancies, as well as number of part-time employees. So here's a case study to consider. You are the manager of an adult medical telemetry unit and you are looking at the budget for 2016 or any year. The average daily census, or ADC, is one measure that can be considered by the manager to project the potential workload of the unit. In this particular case study, that would be 40. The nursing hours per patient day is 8.79. The RN to patient ratio is 1 to 4, and the total FTE is 61.7. So here's the scenario. Because of renovation on the unit, your average daily census, or ADC, has been running at between 28 and 32. The renovation is scheduled for at least 6 more weeks. Your staff is being floated to other units, and frustration is beginning to show. Staff are calling in, and your care model is eroding because you are having difficulty maintaining your RN to patient ratio. I hope you have some ideas in mind as a solution to this scenario. A good solution would be that a staff scheduling council would be called for an emergency meeting. At that meeting, the maximum ADC is determined to be 32 for the next 6 weeks. So the council seeks to remove frustrations for the staff and return to the care model that supports their patient care delivery. Another good solution is that the units that the staff have been floating to should be contacted to find out their projected needs. The staff on the unit are queried and asked by the skill mix and by their shift to volunteer for a scheduled reassignment. That way they have some say in the solution. So hopefully some positive results will take place so that staff understands how much time is left for this renovation. And then enough of the staff are hopefully will volunteer to bring the unit staffing model down to 32. Other units hopefully will welcome the known support with open arms before the start of the shift. And staff who are floating have lessened anxiety because they can plan better. Staffing and staff satisfaction. Nurse retention is extremely important. It impacts satisfaction. If nurses aren't retained, it's costly to the organization. Also, it has an impact on care and collaboration. Patient outcomes are affected. Staffing strategies would include floating. It would be important to make sure that the nurse who's floating to another unit has been trained to work on that unit. Often, units with similar characteristics will share floating. In general, mandatory overtime is not supported by nursing organizations, and that's because it's seen as a risk to both patients and nurses. Another staffing strategy would be planned reassignment. Adequate staffing supports positive patient outcomes. It's important to examine the resources that are available to provide guidance for staffing. There's a Joint Commission Staffing Effectiveness Standard, as well as the ANA Principles for Nurse Staffing. The NDNQI, or the National Database of Nursing Quality Indicators, also has a model. And you can do a literature search. The Staffing Effectiveness Standard from Joint Commission is Standard HR 2.1. The Joint Commission has initiated an effort to begin correlating an organization's clinical outcome data with its staffing ratios to determine the effectiveness of the overall staffing plan. Clinical, service, and human resource indicators. Data on the clinical service indicators are used in combination with those human resources indicators to assess the effectiveness of staffing. Examples of those indicators include, for clinical service, patient falls, skin breakdown, length of stay. For human resources, it would be the nursing hours per patient day, overtime, and nurse vacancy rates. Staffing and outcomes. The goal of dealing with staffing issues is to use available data to improve outcomes. Staffing is all about patient safety and positive healthcare experiences and outcomes. It is important for managers to have the ability to deliver safe and effective care while maintaining employee satisfaction. They should also understand the impact of nurse-sensitive indicators on patient outcomes. Let's look at the types of schedule construction. Decentralized schedule construction is where the nurse manager develops the schedule in isolation from other units. Successful staff self-scheduling is achieved when each individual's personal schedule is balanced with the unit's patient's care needs. Centralized scheduling is where scheduling is created centrally by a team or a staffing coordinator. The advantage of centralized scheduling is that the staffing coordinator or the team is usually aware of the abilities, qualifications, and availability of supplemental personnel who may be needed to complete the schedule. Variables that affect staffing schedules. You can refer to box 14-3 on page 272. There are formulas in box 14-4 on page 273. They include the average daily census, the percentage of occupancy, and the average length of stay. You should be familiar with how these are calculated. Staffing variance. In box 14-5 on page 274, you see an analysis of labor costs per unit of service. This compares the budgeted salary costs per budgeted volume of service with the actual salary costs per actual volumes of service. When there are discrepancies and the budget were over budget or under budget, a variance report has to be submitted, and this is submitted by the managers, and this report explains why the unit is spending more or less money than what is budgeted. It's important when you're reviewing this chapter to read it for understanding and understand the terms that are in this chapter. Chapter 14 has numerous terms related to staffing, productivity, FTEs, and you should have a basic understanding of what those are.